It's 2 in the morning, your child is burning with fever, and the medicine cabinet is empty. You grab your keys with shaking hands, unlock your phone, and search for the nearest pharmacy permanently closed. You stare for a second, thinking it must be wrong. So you tap the next result, permanently closed again. Your breathing changes now, faster, heavier, louder. You try a third location 27 miles away, and it closed an hour ago. This is not some frozen village in the middle of nowhere. This is a normal American suburb where families work, pay taxes, raise children, and expect help to exist when emergencies strike. But tonight, help is gone. And for millions of people, this is not a rare nightmare. This is routine life across the United States. Entire communities are waking up to a reality nobody warned them about. Pharmacies are disappearing one by one, lights off, gates down, signs removed, shelves emptied, parking lots silent. The places where people once picked up insulin, antibiotics, heart medication, asthma inhalers, pain relief, and life-saving prescriptions are turning into dark abandoned boxes beside empty roads. For years, people assumed pharmacies were permanent like gas stations, hospitals, schools, and grocery stores. Every town would always have something too necessary to fail. But that assumption was wrong, because while families were busy surviving inflation, rent, debt, and long work hours, another system was quietly changing underneath them. A system most people never heard of. A machine hidden behind insurance paperwork, contracts, pricing formulas, and corporate language so boring, nobody looked closely enough to see what it was doing. Now the damage is visible everywhere. In small southern towns, elderly patients drive 40 miles for blood pressure pills. In rural counties, diabetics ration insulin because refilled trips cost too much gas. In inner-city neighborhoods, mothers ride 2 buses with sick children just to find antibiotics before midnight. In farming communities, people delay treatment because missing half a workday to pick up medication means losing money they cannot spare. And when medicine gets delayed, sickness gets worse. Minor infections become hospital visits, missed refills become strokes. Skipped insulin becomes emergency rooms. Forgotten psychiatric medication becomes breakdowns. Families never saw coming. This crisis did not begin because Americans stopped needing medicine. It did not happen because pharmacists suddenly forgot how to run businesses. It did not happen because every closed store was badly managed. No. Many pharmacies were profitable in customers, but unprofitable inside the system controlling them. That difference matters more than most people realize. Because a store can be full of patients every day and still be strangled to death behind the counter. To understand how that happens, you need to understand something almost nobody talks about: middlemen. Invisible companies sitting between you, your insurance, your doctor, your medicine, and the pharmacy that hands it to you. They do not manufacture pills. They do not diagnose illness. They do not comfort scared parents at midnight. They do not explain side effects to nervous seniors. They do not unlock doors during emergencies. Yet they control the money flowing through nearly every prescription in America. And where money flows, power follows. These companies decide what gets covered, what gets denied, what pharmacy gets paid, what drug is preferred, what patient gets redirected, and which stores survive long enough to open next year. They are rarely blamed because most people never see them. But their fingerprints are on almost every closure. Imagine owning a small neighborhood pharmacy. You know your customers by name. You remind old Mr. Jenkins to take his heart medicine with food. You help a young mother understand dosage for her child. You catch dangerous interactions doctors miss because you know the patient history better than the computer system does. You stay late when someone arrives, desperate 5 minutes before closing. You deliver medication during storms. You sponsor local school events. You become part of the town itself. Then one day you fill a prescription that cost you $100 to buy, and you get reimbursed $95. You lose money for doing your job. Then it happens again and again, hundreds of times a week. Your shelves move product, But every movement bleeds cash. Your front store snacks, toiletries, and greeting cards. Begin subsidizing medicine. Your stress rises, your staff hours shrink, you stop replacing broken equipment, you skip your own paycheck, you hope volume saves you. It doesn't. Then months later, another charge appears. Retroactive fees, performance adjustments, penalties formulas you were never allowed to negotiate. Thousands gone overnight. You appeal and hear silence.
Quarter yet, gentlemen.
Meanwhile, the chain store across town, owned by a corporation connected to the same ecosystem, keeps expanding mail order services and preferred network advantages. You are not competing on equal ground. You are playing a game where the referee owns the other team. This is how towns lose pharmacies, while medicine demand keeps rising.
We're still waiting
and once one closes, the next becomes vulnerable.
I need my prescription today.
People transfer prescriptions farther away. Traffic changes, habits change, trust weakens, revenue drops, then another location closes, then another. Soon, an entire county has none left. No pharmacist, no counseling, no urgent refill, no walk-in human being who knows what your pills actually do together. Just call centers, websites, hold music, and long drives. For elderly Americans, this can become a prison sentence. Many no longer drive at night. Some do not drive at all. Some rely on neighbors who work full time or relatives living hours away. Missing one refill can mean blood pressure spikes, chest pain, dizziness, confusion, or worse. For parents, it means panic. Children get sick suddenly, not on schedule. Ear infections, fevers, allergic reactions, asthma. Attacks do not wait for standard shipping windows. For workers paid by the hour, every extra trip steals wages. 2 buses there, 2 buses back, 3 hours gone paycheck. Smaller medicine still uncertain. For people managing depression, anxiety, bipolar, disorder, schizophrenia, or seizure disorders, consistency is everything. A delay of days can destroy stability built over years, and the emotional cost is harder to measure than miles or dollars. It is the humiliation of begging rides, the fear of running out, the anger of doing everything right and still being punished, the exhaustion of systems that always feel harder for ordinary people than for corporations, the loneliness of watching your town lose another essential service, while leaders talk in polished phrases about market efficiency. Look at the map and patterns appear fast. Closures hit poorer areas harder, rural towns harder, aging populations harder, chronic illness zones harder. Places already carrying heavier burdens get hit. Again, the same counties struggling with diabetes, obesity, heart disease, unemployment, weak transport, and hospital shortages are often the same ones, losing pharmacies first. Need does not protect communities. Sometimes it attracts exploitation. In cities, the problem looks different, but hurts the same. Distance may be shorter, yet access still collapses. A pharmacy 3 miles away means little if buses run once an hour. Crime makes night travel risky. Sidewalks are unsafe and work schedules leave no room for detours. A person without a car can live near medicine and still be effectively cut off from it. This is why statistics can mislead. On paper, there may be stores nearby. In real life, they may as well be on another planet. And while families adapt, corporations announce closures using words like optimization, footprint, restructuring, shareholder value, strategic alignment, cold language for hot human consequences. They never say a father will miss insulin tomorrow. They never say a grandmother will skip blood thinners next week. They never say a child's infection will worsen overnight because the nearest open counter moved 30 miles farther away. They say efficiency. They mean somebody else pays the price. What makes this crisis especially dangerous is how invisible it remains until it reaches you. Most people ignore it while their own pharmacy still stands. The lights are on shelves, stocked, pharmacist, smiling receipt, printed life normal. Then one morning, a sign appears. This location will close on the following date. Thank you for your loyalty. Suddenly, the abstract becomes personal. Where do prescriptions go now? Who has records? What about controlled medications? What about mom's insulin? What about After work hours? What about weekends? What about transportation? What about everyone else flooding the remaining store? That is how collapse feels in modern life. Not one dramatic explosion, but 1,000 ordinary inconveniences that slowly become danger. A line longer than usual. A refill delayed 2 days. A medicine out of stock. A voicemail never returned. A drive too far for someone too sick. A patient deciding maybe I can skip until next week. And then consequences nobody connects back to. The closed pharmacy that started it. Hospitals see emergencies, families see tragedy, systems see separate events, but they are linked. Every missing access point pushes pressure somewhere else. Emergency rooms, ambulances, caregivers, debt, stress, grief. The cost never disappears. It simply moves from corporations to households, from spreadsheets to bodies, from quarterly reports to kitchen tables. Some towns fight back. Locals organize petitions. Mayors call meetings. Independent pharmacists try heroic. Hours home. Delivery credit tabs for struggling families, personal care no algorithm can replace. But heroism cannot always defeat math rigged by larger powers. Good people burn out too. And when the last independent store shuts its doors, a strange silence follows. No drive-through bell, no fluorescent aisles, no pharmacist asking how you've been. Just another dark building and another service gone from another town. People were told still mattered. This story is not really about pharmacies alone. It is about what happens when essential systems become extraction systems, when institutions built to serve are redesigned to harvest, when complexity hides responsibility, when citizens become revenue streams and communities become numbers on maps. Medicine is only the battlefield where it became impossible to ignore, because everyone needs health eventually. Everyone needs help eventually. Everyone assumes somewhere nearby a light will be on when that moment comes. But millions are. Discovering the light has already gone out. And if nothing changes more, communities are next. More parents will search at midnight. More seniors will count pills and pray. More workers will choose between wages and treatment. More patients will learn. Too late that convenience was never guaranteed. This is the new divide in America. Not only rich and poor, urban and rural, left and right, but those who can still reach care and those who cannot. And once a town crosses that line, climbing back is far harder than anyone admits. Most people think the price of medicine is decided by the company that makes it or the pharmacy that hands it to you. That sounds logical. Make the product, sell the product, collect the money. Simple. But American healthcare stopped being simple a long time ago. Between the factory that manufactures a pill and the patient swallowing it stands a hidden empire. Few citizens ever see, and even fewer understand. This empire does not build hospitals. It does not train nurses. It does not invent cures. It does not stay awake beside a sick child at midnight. Yet it can decide whether your prescription is affordable, delayed, denied, redirected, or financially devastating. This is the power center behind the pharmacy collapse. The middleman class, and in this industry, those middlemen have a name: pharmacy benefit managers. 3 bland words hiding enormous control. Most people never hear the term until a claim gets rejected or a pharmacist sighs behind the counter and says, "Your insurance changed something again." That sentence has ruined more afternoons than most Americans realize, because when insurance changes something, it often means a PBM changed something. A different preferred drug, different network, pharmacy, different prior authorization, rule, a different copay, a different reimbursement formula squeezing the store that serves you, a different decision made by people you will never meet. Imagine a toll road built between every doctor, pharmacy, and patient in the country.
These tomatoes
Now imagine only 3 companies own almost all the toll booths. That is the modern prescription market. They stand in the center of the flow collecting data fees, leverage and influence every time medicine moves. To the public, they are marketed as cost savers, negotiators, efficiency. Experts companies supposedly hired to lower prices and simplify benefits. That is the sales pitch, but incentives tell a different story. If someone earns money each time, complexity increases. Why would they simplify anything? If someone profits from controlling access, why would they surrender control? If someone makes billions in darkness, why would they invite sunlight? This is where the story turns from inconvenience to design. Because many of the rules frustrating patients are not accidents. They are profitable. Features. Take formularies. Most people never think about formularies until their doctor prescribes something, and insurance says, try another drug first. A formulary is basically the approved list deciding what your plan prefers. Covers heavily. Covers lightly or refuses. Sounds administrative neutral even. But placement on that list can determine whether a patient pays $10 or hundreds, whether treatment begins today or after appeals, whether a stable patient is forced to switch medications that were already working, and who influences these lists. Often the middlemen negotiating behind closed doors. Manufacturers compete for favorable placement. Better placement means more prescriptions. More prescriptions mean more revenue. So deals happen, rebates happen, incentives happen, and somewhere beneath those negotiations stands a patient who simply wanted the medicine. Their doctor recommended. They do not see the chessboard. They only feel the move. Now consider a disturbing incentive. If a rebate is calculated as a percentage of a drug's list price, then higher list prices can create larger rebate pools. That means the system can reward expensive stickers while advertising hidden savings later. To ordinary people, this feels insane. Why not? Lower the starting price. Because transparency would shrink opportunities for everyone feeding off opacity. The patient hears one number. The insurer hears another. The pharmacy receives another. The middleman sees all of them. Information itself becomes profit. Then there is reimbursement. The pressure point crushing community pharmacies across America. Local pharmacy buys medication to keep it in stock that requires cash upfront inventory, risk storage, labor systems, compliance rent, electricity staff, wages, and expertise. Then they dispense it, expecting payment through insurance channels. But what if the reimbursement arrives lower than acquisition cost? What if filling a prescription loses money? What if the more faithfully they serve insured patients? The faster cash drains out of the business. That is not commerce. That is slow suffocation. Independent owners across the country describe days where they work non-stop, only to realize volume created losses, not gains. Customers think busy means successful. Sometimes busy means bleeding faster. Why stay open then? Because pharmacists are often stubborn people in the best sense of the word. They know families depend on them. They know older patients panic when routines change. They know rural towns may have no backup, so they keep going longer than spreadsheets say they should. Many mortgage homes drain savings, skip salaries, and hope relief arrives before collapse does. Often collapse wins. Then comes one of the most maddening mechanics in the system, retroactive fees. Imagine selling products all year, believing you understand your margins only to receive a surprise bill months later based on metrics formulas or performance adjustments you never truly controlled. Now imagine that bill is large enough to erase profit you thought already existed. How do you hire staff under those conditions? How do you invest in upgrades? How do you plan inventory? How do you sleep? You do not run a stable business. Under unpredictable clawbacks, you survive quarter to quarter until survival ends. Patients rarely know any of this while standing at the counter frustrated over delays. They may blame the pharmacist for shortages, pricing, or prior authorizations. Sometimes the pharmacist wants to scream, "We are trapped too." But professionalism usually sounds like calm apologies. There is another layer more troubling than hidden fees and reimbursement gains.
Focusing here on the trust section,
because many of the same corporations, operating benefit managers are linked to insurers, pharmacies, clinics, mail order services, data systems, and broader healthcare pipelines. Think about the incentives when one corporate family can influence insurance coverage, steer prescriptions, process claims, own dispensing channels, and analyze patient behavior simultaneously. The lines between referee, player, and stadium owner begin to vanish. Competition becomes theater. A patient may believe they are choosing freely while pathways were nudged, long before choice appeared. Maybe the nearest local store is out of network now. Maybe mail order suddenly has lower copays. Maybe certain drugs are easier only through affiliated channels. Maybe paperwork mysteriously becomes smoother when you stay inside the ecosystem. None of this needs cartoon villains in boardrooms. Systems enforce incentives without speeches. People inside them simply optimize targets, bonus metrics, quarterly goals, retention numbers, shareholder expectations. The result can feel ruthless even if each individual action is explained as policy. That is how structural harm often works. No single dramatic evil, just countless decisions aligned toward extraction. And because healthcare language is so technical, the public tunes out. Spread pricing, network, adequacy, adjudication, rebate, retention, utilization, management, direct remuneration, specialty, tier, synchronization. Words thick enough to hide consequences, but translate them into plain language and the picture sharpens. Someone pays more than necessary.
Welcome.
Someone gets delayed. Someone is redirected. Someone loses a neighborhood pharmacy. Someone profits in the middle. Repeat millions of times. Now ask yourself why reform moves slowly if pain is widespread. Because concentrated profits fight harder than scattered suffering. The companies benefiting know exactly how much is at stake. The people harmed are divided by geography, illness schedules, and exhaustion. A parent dealing with a sick child has little time to study reimbursement. Reform. A diabetic working double shifts cannot lobby between appointments. An elderly widow without transportation is not attending policy conferences. Meanwhile, professional lobbying teams never miss a meeting. This imbalance keeps many broken, systems alive. The people bearing the cost are busiest surviving it. There is also a psychological shield protecting middlemen invisibility. Patients see doctors, they see pharmacies, they see hospital bills, they see drug bottles. Those become targets for frustration. The hidden layer, controlling many terms of engagement, remains abstract and faceless. Anger attaches to whoever is visible. This is why local pharmacists often absorb rage caused elsewhere. Denied claim, high copay, forced substitution. Out of stock because margins no longer justify carrying slow-moving items. The person in front of you did not design those realities, but they become the messenger punished for delivering them. Over time, morale erodes, young pharmacists burn out. Students reconsider careers, owners sell close or join chains to survive. Communities lose another independent institution and wonder why no one stays local anymore. Because local often cannot compete with vertically integrated giants writing the rules around it. And when a community pharmacy disappears, something irreplaceable vanishes with it knowledge. The pharmacist who knew your father reacts badly to one antibiotic. The technician who noticed your mother gets confused when labels change. Color. The owner who quietly extended credit during hard months. The human memory no database fully captures. Large systems call this inefficiency. Real communities call it care. Middlemen also thrive on delay, because delay weakens resistance. If a claim denial takes 3 phone calls, many patients give up. If an appeal needs forms, signatures, and waiting, some doctors switch to easier options. If switching pharmacies is exhausting, Many people accept the preferred channel
power.
presented. Friction itself becomes strategy. Tiny obstacles multiplied across millions create enormous behavioral control. Most people comply not because they agree, but because they are tired, and tired people are easier to steer.
Chart.
Yet the machine has vulnerabilities. Public attention is one, plain language is another. Every time hidden mechanics are explained, simply their mystique weakens. Every time citizens realize complexity is not the same as necessity, reform becomes more possible. Every time a patient asks, "Who benefits from this rule?" the conversation changes. Because many rules survive only while unquestioned. The tragedy is that awareness often arrives after damage. After the independent pharmacy closed, after the stable medication changed, after debt piled up, after health worsened, after trust collapsed. Still, awareness matters because systems built by humans can be changed by humans. But first, they must be seen clearly. So look clearly now. When your prescription suddenly costs more, ask what? Layer changed. When your pharmacy says reimbursement no longer works, ask who said it. When mail order becomes strangely favored, ask who owns the channel. When a town loses its last pharmacy, ask who profits from consolidation. When medicine grows harder to reach in the richest nation on earth, ask why the middle is thriving while the edges fail. Part of the answer sits in offices most people never visit, using spreadsheets most people never read, making decisions most people never voted on. They may never shake your hand, but they can shape whether your child gets antibiotics tonight, whether your grandmother gets insulin this week, whether your town still has a pharmacy next year. That is real power, even if hidden, and hidden power unchecked rarely stays benevolent for long.